Dr. Maunica. She has done her MBBS from Usmania Medical College, Hyderabad, and she has done her post-graduation with a gold medal from JSS Medical College, Mysuru. And she has fellowship in reproductive medicine at Oasis Fertility, Hyderabad. And she has FRM diploma in ART, Kiel University, Germany. And she is a fertility consultant, Ferty9 LB Nagar. And now she will talk on unexplained infertility, what's new. Over to you, Dr. Maunica.
Today is about unexplained infertility. Unexplained infertility is a topic where there's a lot of anonymity surrounding it in terms of its diagnosis, management, or at the very onset, even the definition. Now, the definition of unexplained infertility has evolved over time. The oldest standard definition given by RCOG in 1998 stated that a couple, in spite of trying, if they're unable to achieve a pregnancy even after 1 year, and all their routine, basic, or standard investigations end up being normal, we can attach the diagnosis of unexplained infertility to them. When I say routine, basic, or standard, we are talking about one, from the lady's side, documentation of ovulation. Second, the tubal patency being checked. And from the husband's side, a basic semen analysis. Now, after this, ICMART in 2017 went a little in depth. It stated that in women, the entire ovarian anatomy, the tubal function, and also the uterus, cervix, vagina, and the pelvis also needs to be normal. And from the men's side, the genitourinary anatomy, the normal testicular function, and a normal ejaculate as per the WHO norms. Later came ASRM. The practice committee of ASRM in 2020 stated that as long as there is at least one patent fallopian tube in the lady, with all the other parameters being normal, even then we can consider them to be having unexplained infertility. Whatever might be the various definitions that are given, nobody really attached the significance of the age factor. So the age factor has been studied by the latest ESHRE guidelines published in 2022. They tried to figure out that what could be the significance of this age factor. They found that among all the compiled studies, in women where there was less than 35 years, the unexplained infertility was given falsely the diagnosis in 10% of the cases. And in women, the age factor where they were above 40 years, they were wrongly diagnosed as unexplained infertility in nearly 80% of them. If we go a little in depth, what could be the reason for this false diagnosis? Probably any declining ovarian reserve or underlying endometriosis and various other factors. The incidence now, what we should think is with passing time, we are having advanced technologies, even we are going further in terms of evaluation. We should understand that probably this unexplained infertility diagnosis incidence should be decreasing so that we are finding out what could be the reasons. But however, it still stands as high as 30 to 40% of the couples. What could be the possible factors, the underlying factors in them? What we can see is the tubal patency, the semen analysis, and a documentation of ovulation. What we are unable to see, has the egg properly after rupture entered into the tube? What was the tubo-ovarian function? Was the tubal fimbriae able to collect the egg? And after entering into the tube, now millions of sperms are deposited in the uterine cavity. How many of them were able to navigate the uterotubal junction and reach the oocyte? And after reaching the oocyte, fertilization is a complex events, capacitation, sperm acrosome reaction, the oocyte zona penetration has to take place. So all these are they occurring well. And after formation of the embryo also, it needs to traverse the remaining length of the tube and ultimately reach the uterus. And the dialogue between the embryo and the uterine endometrium needs to be successful. Only then the implantation event occurs and the lady ends up with the pregnancy. So they said that probably in majority of the couples where unexplained infertility is given as the diagnosis, these could be the possible undetected factors. They are subtle tubal dysfunctions, endometriosis, premature ovarian insufficiency, and immunological factors. These are the gamut of investigations as basic, which are required both from the women's side and from the man's side before we give them this diagnosis. Apart from the above tests, ESHRE also stressed the importance that we could add on 3D scans, so we are excluding uterine anomalies in these ladies. What is the role of a routine diagnostic laparoscopy or a screening hysteroscopy? They said it is not needed as long as the HSG report is normal. Only in the event the HSG report, there is some abnormality that we find, or they have a history of any ectopic pregnancies on endometriosis. To rule them out, yes, we can go ahead for a laparoscopy or a screening hysteroscopy. Various investigations apart from what we have discussed prior, all these investigations, testicular imaging, the sperm DFI or anti-sperm antibodies, thyroid screening or anti-thyroid antibodies, celiac disease screening, genetic testing, all of these do not have a role in unexplained infertility. Coming to management, unexplained infertility couples, most of them, they do not prefer expectant management. They have been trying naturally, the ladies having regular cycles. In the sexual act, they do not have any problems that they are facing. And in spite of that, if they are unable to achieve a pregnancy and they come to us, when we give them this diagnosis and tell them, you go back to trying naturally, they do not like it. Whether we have to initiate or delay treatment for the couple, it depends on various factors. We need to individualize. What is the age of the lady? How long has she been having the problem of infertility? And what is her desired family size? Expectant management, one of the studies showed that in the first year, if they were asked to try naturally, nearly 14% of them conceived. And in the next 2 years, 35%. And over a span of 3 years, nearly up to 80% of them could conceive naturally. NICE guidelines in 2013 stated that they should be allowed to try expectant management for 2 years. And after that, also if they do not get pregnant, maybe we need to go ahead and advise them IVF, especially in women less than 35 years of age. Numerous prediction models have been designed in order to predict the chances of a spontaneous pregnancy over the next 1 year. Most popular model being Hanault model or the synthesis model. This model took into consideration certain factors like female age, the years of subfertility, primary or secondary, percentage of motile sperms, and the referral status. This referral status also carries importance because they found that if the couple was being referred by any random clinician, the chances of spontaneous pregnancy was much higher in comparison to a couple who was being referred to the fertility experts by a gynecologist. Coming to management in couples with unexplained infertility, broadly the treatment we know is, one is the ovulation induction, next going ahead for a IUI, and last being IVF. Now in the beginning part, they found that all this ovulation induction combined with the timed intercourse, whether we are using oral ovulogens or gonadotropins, all of them did not prove any superiority to a expectant management. And the same goes for even a natural cycle, IUI. When an IUI is not combined with any ovarian stimulation, performing in a natural cycle, IUI also showed no superiority in terms of live birth rate to expectant management. A strong recommendation and a grade A level evidence shows that what is proven to have a role is a IUI combined with ovarian stimulation. This could be probably because we are able to make sure more than one follicle is growing and more number of oocytes are rupturing and ovulating so that they have higher chances at a pregnancy. And in IUI combined with ovarian stimulation, again the doubts arise whether we need to limit them with oral ovulogens or go ahead with gonadotropins, or is it a combination? And what kind of gonadotropin? Should we do a human menopausal gonadotropin or a follicle stimulating hormone? Here also they found that all these have similar success rates in live birth rates. There are differences in terms of multiple pregnancy rates and also OHSS rates. Otherwise, the ultimate outcome that we are aiming for, live birth rate, is not very different. Single IUI versus double IUI. Here also, single IUI versus double IUI, there is no much significance in terms of clinical pregnancy rate. The recommendation according to the practice committee ASRM 2020 states that we need to go ahead for at least 3 to 4 cycles of IUI combined with ovarian stimulation. And even then, if the couple is unable to achieve a pregnancy, then follow it up with an advice towards IVF. There were trials that were conducted, one of it being fast track and standard treatment trial. This was published in Fertility Sterility Journal 2010 August issue. Here they tried to evaluate what is the role of an FSH IUI in women suffering with unexplained infertility and particularly belonging to the age group of 21 to 39 years. All these couples, the women, they were randomized to 2 arms. One arm, they followed the treatment of 2 cycles of clomiphene citrate with IUI, followed by 3 cycles of an FSH IUI, and even then if there is no pregnancy, followed up with nearly 6 cycles of IVF. And then we have another arm that was the accelerated arm. Here, they first tried with 3 cycles of clomiphene citrate IUI, and if there was no pregnancy, omitted the role of FSH IUI and directly proceeded towards IVF. When they compared the cumulative pregnancy rates in both the arms, clearly the latter arm, that is the accelerated arm where the FSH IUI was omitted, they showed higher cumulative pregnancy rates. And also they found that that particular arm, the cost of treatment to achieve one live birth was also comparatively lower, and the time to achieve the pregnancy was faster. Next came FERTY trial. This was again unexplained infertility, but the women belonging to a higher upper spectrum, that is 38 to 42 years, where their ovarian reserve is rapidly declining. So here they considered as long as if they were unable to achieve within 6 months after marriage, they can go for the treatment. Now in this treatment, they were again randomized to 3 arms. One arm went for 2 cycles of clomiphene citrate IUI and then followed it up with IVF if there was no pregnancy. The second arm, it was 2 cycles of FSH IUI followed up with IVF. Or the third arm, it was a direct IVF that they attempted. In the first arm, the cumulative pregnancy rates was 21.6%. In the second arm, it was 17.3%. In the last arm, where they immediately were advised IVF, it was nearly 49%. Clearly, immediate IVF demonstrated superior pregnancy rates in comparison to the other arms, even with fewer treatment cycles. What could be the reason? Now, we saw that the women belong to the latter spectrum, that is 38 to 42 years, where their reserve is rapidly declining. If in these cases, if we are attempting the IVF early, probably we could retrieve more number of eggs, make more number of embryos, and give them a higher cumulative pregnancy rate. So this could be a thought that we can follow, like what is the justification in advising a couple to rapidly or directly go for IVF? This could be based upon the diagnosis of what is the ovarian reserve in the lady. So I would like to summarize my talk by stating that unexplained infertility couples have to be stressed over and over again that they do have a chance at a natural pregnancy or natural conception. There is no role of a natural cycle IUI. What is recommended is a stimulated IUI, that is IUI combined with an ovarian stimulation. Whether we need to directly advise or wait before we advise IVF in couples, it depends on numerous factors, like the age of the lady, what is the duration of infertility, and what is the desired family size. She wants to stop at 1 child or have 2 kids. So all these factors need to be taken into consideration when we advise them. Thank you.